back, everybody. This is the Prehospital Paradigm Podcast. I'm Scott Wildenheim. I'm going to sit on my hands. I'm apparently not allowed to. Apparently, I'm not allowed to use my hands to introduce everybody. But this guy over here to my left, we got Caleb Ferroni. Across the way there, we got Ray Pace joining us and Dr. Donald Spanner. Thanks for coming back, man.
Hello. Thank you.
I am gonna. Sorry, I can't sit on my hands and not point and talk. So, hey, we want to talk about shock today, and let's make sure we don't make this, the quintessential, shock lecture that everybody's used to, and let's really kind of work through, how do we translate all this knowledge we have about shock into, utilitarian things that we can act upon in the back of the
right.
Why is that, in-depth knowledge? We got some stuff up here on the screen in front of us, but oxygen, glucose, CO2. Is that really important to an end-level provider that's just trying to save a life at the, the back of the truck at 2 o'clock in the morning, right?
Wow, what a great question. And I have to tell you, it's kind of making me think about everything else that we focus so much on time for. So we sit here and talk about stroke,
right,
and we talk about 2 million neurons a minute are lost because time matters. We talk about heart. Time is muscle. And so we have all these fantastic sayings that get the paramedic very focused on getting the job done, moving rapidly to the proper facility, getting the right patient at the right time to the right place for the right care. I mean, we have all this focus in place, but it all comes down to the cellular level.
Right.
So here we have the neurons of the brain, probably the most sensitive to lack of oxygen and glucose, the ones that certainly suffer from damage in 4 to 6 minutes. We talk about the heart that can survive significantly with collateral circulation, but certainly compromised with lack of perfusion to the heart muscle itself. And yet shock encompasses all of it. It's all the tissues, all the cells of the body, and all our living tissues require oxygen, glucose, but not only requires that it's perfused at a level that will allow the production of our energy molecule ATP, and not to be, detailed oriented, but if we don't produce ATP in an aerobic state, we enter an anaerobic state. Then lactic acid builds up. Then lactic acid is causing myocardial dysfunction as we live in an acidotic state. Right. And this whole circle and spiral of death is all part of our shock event. So I think we really need to respect what shock is. We need to respond in a much more aggressive way. I think that we follow protocols, that when somebody's in shock, we give fluids and pray that they get better.
Right.
And that simply is not an adequate response to shock. And today I hope we talk about the different types of shock, how you recognize the different types of shock. And if you recognize them, you'll be able to respond and get somebody out of shock before they spend 20 minutes en route to the hospital killing off tissue and cells.
Let's talk a little bit about that point you made. We're time sensitive on so many other things. Do you think because shock is so fairly common and so, it's ubiquitous? What day goes by in our care we don't have somebody in some type of shock, right?
Absolutely.
We're almost desensitized to it. It's kind of like the concept of oxygen as a drug, right?
Steal his line. Garlisi says it's the only common pathway to death.
Oh my God, right.
That's a great line.
And I love it. Yeah. Because we dive so deep into STEMIs and strokes. You got to get through shock to die. So we need to start looking at it that way.
Yeah,
I love that.
Those are heart shocks and brain shocks, and it's at the end of the day, right? It's localized.
100%.
We talked. Yeah, it's because it's so ubiquitous. Do we have a tendency maybe to undertreat it, or to your point, not have that sense of urgency in attacking it, right? So I know you and I had a conversation about a case. It was an anaphylactic case, and whatever it was clearly anaphylactic shock, not anaphylactic reaction. And our discussion was they needed to attack that shock because it's such a fast-moving shock, right? It evolves so quickly. But let's take that outlier. We'll come back to that. We're going to hit that hard here in a little bit.
Yes.
But let's talk about everything else. I mean, even the slow-moving shocks, oftentimes we get them late.
Right.
So sometimes, we're already behind the 8 ball, and we sometimes don't have that same sense of urgency, right?
I think you need to maybe step back just a little and kind of realize what type of shock you're dealing with. And that sometimes will move you in the right path to get that person's life saved, frankly. So I think we just start off with just breaking down the different types of shock.
Yeah,
and I know you said you don't want it to be like another shock lecture.
We can go through this.
But you have to break this down. So, for example, we have our hypovolemic shocks. So we're looking at somebody who is either volume depleted from dehydration, diarrhea, vomiting. Basically, their volume is down.
Correct.
Or hemorrhage.
Right. And in that same category of hypovolemic shock is hemorrhagic shock. And the thing that I find interesting, because this is what you were kind of detailing, is how do we underplay it? Well, here's an example. Somebody, for example, in hemorrhagic shock, they don't even drop their pressure till they lose at least 30% of their blood. So somebody comes along and recognizes a significant trauma, who's lost a lot of blood, and the person's already hypotensive and tachycardic. They start their line, they control what bleeding they can, and they give them the bolus. And in our protocol, so that we standardize throughout peds and adults, it's 20 cc's per kilo of whichever crystalloid, but frankly, it's normal saline,
usually.
And those individuals get a better pressure. And then the medic caring for this individual feels warm and fuzzy. No, I mean, seriously.
No, they see good numbers on the machine.
They see good numbers, and you get this sense of well-being. Well, all you really have is a transient moment in time. Certainly, crystalloid is not going to stay within the intravascular system, and they're going to drop again. But the recognition that, my goodness, they were hypotensive. That means my hemorrhagic shock patient has lost more than 30% of their blood supply. And if they don't respond appropriately, they've lost over 40% of their blood supply. And they need blood and a surgical center to care for a significant traumatic event. But that's just looking at our hypovolemic shock. That same paramedic in that same trauma has somebody who has no air exchange on one side of their lung and is moving air perhaps on the other side, may or may not see some JVD, and this person is hypotensive with JVD.
It's a completely different shock.
It's a completely different shock. You're hypovolemic. If it is, in this traumatic case, hemorrhagic shock is going to have flat neck veins. Our paramedics have to get used to looking at the neck and recognizing this. With flat neck veins, the chances are you're dealing with a volume event. With big neck veins and lack of air transport, you're in a completely different category of shock.
It's a pressure event.
Yeah, well, this event is obstructive. And in trauma, that's only going to be three things. I mean, you're either dealing with a tension pneumothorax, a pericardial tamponade, or not at the moment of trauma, but perhaps during recovery, or perhaps it wasn't traumatic. You have a massive pulmonary embolism. What's the paramedic going to do in that pre-hospital venue with the trauma patient that has lack of air movement with trauma? Okay, not lack of air movement from COPD or something, but lack of air movement from or asthma from trauma. This individual needs to be needled, and that's a life-saving event. I mean, listen, if you know how I am, guys, if if I go too military, because y'all know I've been downrange multiple times, stop me, okay? But I have a whiskey, which is what we call medics in the military. I have a whiskey who he was a specialist, E4, and I had a sergeant who took a round in the chest and probably had a hemopneumo. In fact, he did. But he needled his chest and got a radial pulse back. Obviously, our medics in war zones are not doing blood pressures, but got a radial pulse back. Lost the radial pulse, needled him again. And he was a good distance. He was probably an hour drive to us. When he got in, he had needled his sergeant's chest 5 times.
Amazing.
It was.
Yeah.
But he's recognizing not just what could be hypovolemic hemorrhagic shock, he recognized that he wasn't moving air. This was definitely a tension pneumo. He sees the JVD, and he makes a move. Now, this is like a 19, 20-year-old kid.
Right?
And he looked at me, and he goes, Doc, did I do the right thing here? This is my sergeant. He's worried about his sergeant.
Right.
He goes, I needled him 5 times. I looked at him, I go, you know what you did? You saved his life. That's the kind of response we need. Recognize the shock. If he would have just thought that this round that he took in the chest was all hemorrhagic hypovolemic shock, he's going to pour volumes into this guy, which doesn't help a penetrating hemorrhagic shock patient. It dilutes the clotting factors. It does everything but what this person needs. And to go one step further and recognize this could also be obstructive shock. Yep. Okay? Later on down the line, what if a patient who's had trauma develops a significant infection? We're in a completely different category now. We're in a category of sepsis, which is distributive shock. So let's talk about our distributive shocks. We have our sepsis, which is probably the most common. You mentioned anaphylactic, which we'll talk separately about.
Yeah, let's.
And neurogenic, certainly in trauma, spinal cord injury. But we also remember adrenals and medications that can vasodilate. All of those can be distributive shock. And in this situation, you better get on the stick and press that patient. So you must recognize that third category of distributive shock. And lastly, is the heart pumping? And if the heart's not pumping, you got to recognize cardiogenic shock. And I don't want to make this just another shock lecture, but I think it's critical that we go through the 4 categories so that you can make a decision on what it is you're dealing with. And if you want more specifics on how to tell the difference, I'd be more than happy.
we're gonna get into that. So there was a lot to unpack there, right?
I'm sorry.
That's great. So let's start with. I mean, you made an excellent point to begin with, which was for your, for any of your volume depletions, right? There's basically 2 different kinds, right? You can lose body water, or you can hemorrhage blood, right? And that is an important differentiation. I don't know if you guys have had in QA, I certainly have, people that recognized, right, that the patient was volume down, but they didn't make that differentiation, right? And then when you go to QA, oftentimes it's like, well, their blood pressure is low. We're supposed to fluid bolus them, right? And in some cases, it was, well, we're supposed to limit fluids because they're thinking trauma, they're thinking hemorrhage, right? When in fact that patient had diarrhea, vomiting, they had non-measurable body water loss because they were sweating or something like that.
A lot of this can be handled through the QC handling of the patient, though. Your questions, your OPQRSTs, your sample histories.
Yes.
And if we're doing a hands-on exam, we should be checking radial pulses, because that would have been the difference there. Very, very hard for a lot of EMTs and medics to figure out how much blood loss there was, especially if it's in the abdomen, right? But even more so when it's on the floor. If you look at 10 cc's of blood dropped on a concrete floor, it looks like a lot more than 10 cc's, right? So you had mentioned some of the shock criteria there for hemorrhage. I think up 15 to 30% is stage 1, 30 to 40 be stage 2, and anything over is...
So less than 15% is stage 1. 15 to 30 is actually stage
2, stage 3.
30 to 40 is stage 3. That's really the first time you're going to see hypotension. The first thing you're going to see, believe it or not,
Urine,
is narrowing pulse pressure unless it's distributive. Okay? And the next thing you're going to see in stage 2 is tachycardia. Barring the fact they don't have beta blockers on board or calcium channel blockers.
There's a bunch to talk about there.
Talk about that. And then, of course, stage 3 is between 30 and 40%. Stage 4, sometimes referred to as the point of no return, is greater than 40%. We're talking now about hemorrhagic shock.
Yeah, and TXA is a great medication that we have now. But I think a lot of what we were just talking about that came up in class the other day was, we have normal saline at our disposal, and we've talked about this before. It's very acidic, too. It's 5.0 pH. So we're dumping all of this into them, and it's not helping much either.
So there's a whole controversy about that, and you'd have to decide what camp you're on. Okay, should we do lactated ringers? Should we do saline?
Balanced solutions.
Some studies have shown that this acidotic thing that everyone worries about is with larger volumes, over 3 liters. So I think that's certainly something worth discussing. The idea that lactated ringers would be in a less acidotic environment, certainly we do talk a lot about that.
And then the other thing I think that's worth mentioning is we did IV lab the other day. That's why I'm all poked up. Your cannulas have different fluid administration volumes.
Yes.
And I don't think anybody takes the time to really notice that sometimes. A 22 isn't going to get you what a 16 gets you. And you really have to look at how much you can actually administer through that cannula.
Such a good point.
If you need a volume resistor.
Short and wide is the radius that we're looking for. And I think that's so important because you'll see folks, even in trauma centers, put like triple lumens in. So now you have 3 ports.
3 small.
That are small and really long, where, I think the best thing that you'll see trauma centers that really know that you need volumes of blood rapidly, they put introducers in, which look like garden hoses,
yeah.
Because exactly what you're saying, you've got to get these folks taken care of.
Yeah, I agree. Well, I think one of the things, too, is I think hemorrhagic shock, I think we focus more on, and I think we actually, in my opinion, we focus less on that person that's volume depleted.
Yes.
They just have the flu. They've just thrown up a lot.
But they're in shock.
But they are in shock, and I think a lot of times providers overlook that and that they do need fluid replacement. You're really actually going to change your patient because we will see that return. I kind of look at someone that is depleted, almost like a diabetic. We see the return on investment. So if their sugar's low and we're able to give them D10, we make them all better really fast, right? I look at someone that's dehydrated, that's had the flu, thrown up, or even let's go down to like our infants or our toddlers now that's had the flu, where they don't need to lose as much volume to become depleted.
Correct.
They're pale and they're feeling blah. You start an IV, you're able to fluid resuscitate them, and then totally different kid on the way to the hospital.
Right? Young enough, look at their fontanelles. There's just so many.
So I think it's
a great point. Really,
his point is well taken. Caleb's point is well taken. As the story tells, the story makes the case, right? And how often, the experienced provider, that's what they step back and say, what is this story telling me, right? What am I doing with this information?
But I think Ray said something I want to touch on because he talked about kids. Those little buggers, they do well till they don't. Where the rest of us are going to show our illnesses and show that we are declining and slowly going down this hill, they fall off the cliffs. So you have to anticipate this. So a kid that looks dry but still maintains their vital signs needs to be treated as aggressively in a hypovolemic state as one that is already crashing, and everyone knows what to do with that. So I thought that was a really good point.
Said another way, your earlier point of you're not going to see hypotension until later stages of shock, right? If you're waiting for hypotension, you're waiting too long. That
Right.
should not be your indicator to engage, right?
No, and we don't have these patients on Foley catheters. You're not seeing the urine output, which I think drops off pretty quick too.
But we do have tools at our disposal, right? Let's assume people are actually counting respiratory rates. They're not. But what we can't. But what tool do we have? You
Capnography.
put the capnography on.
Yeah.
So not only are you getting, and there's no way we can do a shock lecture and not have done dive somehow on capnography. So I'm just going to set that aside. The CO2 value itself being incredibly utilitarian, but you can look at that respiratory rate, right? You can look at the heart rate. There's all these
There's
these
really
clues.
no excuse
Right,
not
there's
to.
really
I mean,
not.
I just had a meeting with Palmidine last night, and they have the nasopharyngeals with capnography on them now. I mean, it's.
Yeah, we have all these tools at our disposal, but it really reverts back to a lot of the basic ones. You know, a good assessment, counting respirations, looking at their heart rate. I mean, end tidal is great, and I don't want to go down a rabbit hole with that, but, you know, I look at end tidal like
he's got you.
it's a live feed to tell me how my patient is perfusing to an extent.
Absolutely.
You know, and it's such a good tool. It's an EMT skill, and I always try to drive that home when I'm teaching my lectures.
Yeah.
This is an EMT skill.
Yes.
That's why we push it so hard. So even in the more rural areas, maybe you don't have that paramedic, but those good EMTs with good assessment skills are at least knowing where my patient is at. You know, maybe that means, okay, I need an intercept on the way to the hospital. But they know it's time sensitive and they get moving. So,
But just like
I think the vital signs in your assessment is huge.
Yeah.
A big proponent of end tidal. Use it, and we use it a lot in our organization as well. But it really reverts back to, I hate to say it, basic assessment skills, heart rate, breathing. Like, these are simple things.
They are.
Why are they breathing fast? They're in shock.
Yep.
But
They're
when
compensating for a metabolic acidosis.
everybody
Yes.
here QAs charts, and everybody here has had to QA somebody because they
Missed
missed
the
the basic stuff, or they were trying to, some justification why that isn't clinically significant, right?
And
They were
surely
nervous.
could
They
have
were
been-
excited.
could
There
have
was
been
something.
dealt with if we had just completed a good hands-on set of vitals. I like to use the word hands-on because if I'm not feeling a radial pulse and looking at my monitor for that, I don't know if it's bounding, if it's weak, if it's you gotta put your hands on the
Absolutely.
patient.
We're in a
I'm
hard
getting
time.
worked up.
We're in a
Well, to Caleb's point, I dislike, because hate's a strong word, I dislike the provider that's standing there with the iPad. How long have you been sick? Okay, 2 weeks. Right? I plug it into my little iPad. When did it start? Are you allergic to any meds? And it's like, how about you put the computer down and you go assess the
And
patient
you know what?
and talk to them,
And I'll,
get on their
I'll
level,
fall on a
take a
grenade for
good
this one because I'm horrible
get a good
about
look
that.
at the
I
patient.
don't get a lot of squad time anymore, but when I do, if it's a basic run, I'm like this, and my two guys are helping me, and I've got that luxury. But that's the patient I'm going to miss something on.
correct.
And that's the one that's going to get me because I didn't pay attention to it. And you're exactly right. It's the ones it's the hemorrhages, it's the bad traumas that I throw the thing away. Well, that should be us on every patient. I should be meeting you for who you are.
Yes, I like it. I think sometimes we get a little caught up on it. Well, I got a chart. There's time for that.
There's time for that.
There's time for that. We really have to focus on, and I'll revert back to what a physician always told me. When you walk in the door, your assessment starts then.
Yes.
So if I can take a look at you
Yes.
from the door and I see this patient
Sick or
sitting
not
on the
sick.
couch that's pale, you can tell that they're sick or not sick right out of the gate. I think that's a big thing. We do that on the fire ground. When I pull up and the house is on fire, we give a scene size up. It's the same difference when we're looking at a patient. Is this a patient I want to be time sensitive with? I want to get going, or is this somebody that has good color, looks at me as soon as I walk in the room, starts a
And this
conversation,
is
upbeat?
dynamic. That may change.
Correct.
And that's why we reassess. And your patient can go from not sick to sick or from sick to not sick if you fix them. We had an SVT the other day that 6 milligrams converted, which was amazing to me of dentists, and I've never heard of that working. But
It works that way for me every time. You know why? Because I've given it so many times. I know you got to bolus the snot out of it.
Get a
So I
running
always
start,
have
yep.
a 30 cc
I
syringe
was
behind
not
it.
with the guys in the squad, but they told me that. I was like,
Yeah,
it's awesome.
It is awesome.
But he went from sick to not sick.
Right.
And it can happen either way. But we have to be diligent about
Yeah. You have to be engaging with your patient. You have to look at them. You have to talk to them. You have to actually listen. That's probably one of the biggest points, right? You know, I'm sure you see a lot of patients in the ER, and they've told you the story a couple times, but that second story might provide maybe one of the key factors that you really need to hone in on.
100%. Your history is 90% of figuring out what's going on. 100%.
And when it comes down to the physical assessment, right, I think it's easy, specifically in the, let's say, the last 10, 15, 20 years where technology has evolved so rapidly, right?
Yeah.
So in some regards, we're kind of sending a mixed message to a young provider set, right, which is, hey, you got to do the basic stuff. But capnography is you know, a really utilitarian thing. And, you know, that age group, of course, is going to gravitate towards the tech because that's what they understand for, you know. Pulse oximetry was just coming, was just getting on the truck when I started EMS, right? I remember a time without a pulse ox.
But
I remember a time without a glucometer, right?
Yeah.
And everything was stick and rudder, and everything was, you know, patient assessment
presentation.
You had to formulate that entire plan based on that.
Lactate levels in the field now for sepsis, and whether or not you are on that board or not, I'm not sure, but. It's another prognostic toll. So
John is sitting on the other side of the thing. We're just talking about
point of care,
point of care testing and basically full panel lights and whatnot, and where that fits in. And let's be realistic. And I'm not telling the world out there that we're doing that tomorrow.
It's coming.
But I bet by the end of my career, right?
100%.
I expect to be doing ultrasound, and I expect to be doing some point of care testing.
Medics are going to be diagnosing QSOFA criteria for sepsis and starting antibiotics in the field. I mean,
well, we are doing that in some of our areas.
Fractures,
Right.
So I see it getting bigger. But you're not going to give that to people who aren't showing themselves worthy of it. So if we're not doing good quality care in the field, that gets picked up on the QC end, and we're not going to, there's give and take here.
So who are your best medics? Wouldn't you say it's the ones who took their EMT basics seriously?
Yeah.
And formed a foundation?
Or did it for a period of time before they became a paramedic?
Well,
but this shock that we're talking about today, your basics and your basic skills have to be right in front.
On point, yeah.
Because if they're on point, just like you said, you're going to be heading down the right path, and your history and your basic evaluation is going to send you where you need to be so that your paramedic...
Your advanced procedures,
your advanced procedures can now
your interventions will work, yeah.
I know I've said it before, but it takes a good basic to sit there and say, hey, Mr. Medic, he's not breathing. And you're looking at the monitor still like, oh, or that's the good basic. Or, hey, did you do a sugar on him? Because he's pretty lethargic. Or
and listen. I mean, that goes back to the other point. When we talk about high reliability care, especially in the pre-hospital environment where it's incredibly chaotic, and getting high reliability care is quite variable. Sure. You got to listen to everyone. Everyone gets a voice. Everybody has something that they might add to saving that patient's life.
Let me expound on that just a little bit. And I think we have generally gotten better. So some of the things that the changes that National Registry has made has allowed us to be a little more practical in how we teach the paramedic program.
Agreed.
All right. There was a lot of arrogance that was kind of coupled with, this is the only way to do business, and you as the paramedic or you as the advanced provider, I think they may have kind of set that stage up. We came out, we were so good at those skill sets, and we weren't really taught to seek input, and we were testing out our team. I didn't have an assistant. The team. I didn't have an assistant. I didn't have somebody else. Look at our test out now. We're given another part. We're given a partner. We're allowed to use a reference. If I do something wrong, right, in a registry test out, right, the partner that I'm assigned for that test out challenges me on it and says, do you really want to give 100 liters of fluid, or did
And
you
to
mean
your
100
point-
milliliters, right?
Correct.
Which is
5 years ago, even that wasn't the case at registry. So this is they've recognized this too, that it's a team approach.
correct. I am happier the direction.
The only
we're
thing that
taking.
registry won't allow you to do is just call the doc for everything. Hey, I'm stuck on question 3.
But I mean, I'll use my own example. I came out of paramedic school a cocky asshole, right? I mean, it just
What's changed?
nothing.
Shots fired.
27 years is what's changed. But really, and what I've learned over time, and to listen and to absorb and to engage and hell, listen to the patient, let alone my partner, right? That developed over time, and I think we're in a much better time now in that regard.
The little tricks and tips that I've learned, albeit half of them have been with you, that we're just screwing around and figure something out, but I've learned from the old basics and from the old generation that said, oh, there's a better way to do this, kid. And if you're too arrogant to sit there and say, show me, why would that? We're growing together, and we have to, we're all growing together.